apologize if we're a little late.
We're still with it.
This is also posted on D2L. Oh, yeah, I didn't know it. We posted last night. It's on D2L. Last year when I actually, Professor Fetters had already left the program because she taught his dot last year. I didn't teach last year. So I had put together a lecture because I taught the dermatology course. And I gave them a series of lectures because I feel like, and I've told you guys this before, one of the hardest areas to be able to document is derm, because you have to be so descriptive with it. It's not that you don't have the ability, but oftentimes we're just lazy or tired or just want to write down it's a red rash on the right arm, and unfortunately you can't do that. I think musculoskeletal and derm are two of the hardest things to have to document in a patient's chart. So last year I put together 3 lectures that I'd given to them over the course of their 3-week block. I'm just going to give you one of them. The other 2, I'll just, because it's a lot. The other lecture I can just give to you, email it to you, because it will be actually talked about your other courses or your other lectures. It's over morphology. Morphology is the descriptive terms that we use to describe rashes or skin lesions. So like a papule versus a macule versus a wheal versus urticaria. They all have very specific measurements and descriptions to determine if it is a papule versus this versus that versus. It is an excellent resource. I put it together last year from DeGowan, so again, I try to do as much as I can in the PowerPoint format so you don't have to go look at your book. But I will email it to you and you can use it throughout this course to help you better understand what those, when you hear those words, you're going to be like, what is a papule? What is a maculopapula? What's macular? What does that mean? So I'll give it to you. I will not write test questions from it. It's just for you to utilize. The other thing that I put together for them, and I'll give it to you, we can pull it up at some point. It's just example documentation. Like if I were to look at a rash, how would I document it? Or if I were to look at a normal skin, how do you write a normal skin in your medical document? I have that for you, so I'll give those things to you. This is the one that we're going to focus on for this time period. And again, this is your physical diagnosis concentration, or not including any of the others. I have a guess.
We do. This is Cassidy.
Sorry, I didn't mean to. Okay, go ahead. You're just sitting in today. Are you in
Yes.
all day long?
Till noon.
Okay, cool. Awesome. Okay. So here are the lecture objectives. Nothing different there, just read those on your own. This is taken verbatim off of your phys-di sheet, so no curveballs there in regard to what my expectations are of you for phys-di. And again, this is pretty much all-inclusive for what you would be doing in any primary care or family medicine type practice. This is not cutting it short for you. And it's actually probably one of the more simple, besides endocrinology, it's probably one of the more simple phys-di components, because you're just utilizing your eyeballs, you're looking. You can definitely palpate or touch or have tactile sensation, because you're going to feel warm if something's hard or something's soft. Is it rough? But again, it is mainly visualization, inspection, and being able to take what you see and saying it in a very intelligent way on a piece of paper, or on a phone call when you're doing a consult, or telling the patient. So, skin, hair, and nails. Cap refill is in there. Professor Fetters had it in there last year, and that's fine, I kept it. I do believe, though, cap refill might also be in your cardiology section as well, but I did keep it in there. It's not the first time you've heard cap refill, correct? Who in here has not heard of the term, have heard of cap refill? If you have, it's totally cool. That's why we do this. Hello, that's okay. And then if you look down in the notes section of this, I've written skin turgor as well. Do you have it? What is it? Oh, I thought you were asking if you have lectures. Oh gosh, do you not have it? stop me. Because oftentimes people will do certain components of physical exam, and they're like, where's that go? Does that go there, does that go there? Skin turner also goes into, you can put that in the skin, the derm, or the integument section. That's totally cool, you can do that. Have you heard of skin turner? It's tinting of the skin, it helps you determine someone's fluid balance, if they're dehydrated. You can pull up skin on the back of the hand and let it just hang there for a bit. There's a slide here in a little bit. On kiddos, you can do it on the glabella. That's where you do it on pediatric patients. But on, you'll only ever apply see people do back here. But anyway, that's also a component of this section. And again, the two main components that we're utilizing are inspection, and then palpation or touch. These components here written out, I will get to later on in the lecture in regard to what those actually mean. Is everybody okay with that? And also, when we go through this lecture, try not to get frustrated. Lesions is a word that we use in derm, just like that means everything. If I see something, it's a lesion. Lesions can mean rash. They're kind of interchangeable. When I think of lesions, I think of like a very well-defined, circumscribed area that's sitting on someone's thigh or arm. When I think of rash, I think kind of, but they do in your book, Indigo, and use those two words back and forth. So don't get, just remember that. Necessary elements of a dermatologic history. I kind of looked at this last night to make sure it is, up to date. I mean, it's been a year, but just to make sure there's not anything new or anything. I hate giving old lectures, so make sure there was. And I did actually added some new stuff in, changed some stuff around compared to the lecture from last year. I've probably told you guys this before, but derm is one of them, for me anyway, this is a personal thing. I don't really like derm. And the only reason I don't like derm is because I'm pretty stinking smart. I can walk into any room for the most part. If you give me enough time and a competent patient that's appropriate with what they're telling me, I can figure it out. Dermatology is one of those things that I'll walk in there and I will walk out and go, I have no idea what that is. And I hate that, don't we, right? We don't like that feeling of not knowing. I gotta know when I walk out of that room. Man, I'm telling you right now, pediatric rashes, I'm just like, I don't even know. And I don't even try to and it's okay to do this. You don't want to sound ignorant or anything to your patient. But there are often times I will tell parents or even the patient, I'll say, look, this could be about 10 different things. And I'll give them like the top 2 or 3. The beauty of dermatology is we use steroids for 95% of all things dermatology. So you can say, we're going to give you trial steroids, you can see if it gets better. If it doesn't get better, we'll do something else and try to figure this out. But derm for me is just, because if you're a good PA, if you really want to try to figure it out, and I'm not talking your everyday green work, I'm talking like something serious, like I have this bizarro rash, it comes every 3 months. I mean, something that you're complex and you're going to have to really piece out. It can be frustrating for you, so just know that, and that's okay. Because again, I think derm is one of those things that you walk out of the room and you're just like, don't know what that is. Is anybody here just really burning to go into derm? Like that's something you really want to do? That's cool. I had a really good friend of mine in PA school that is what, and she did it, she loves it, And she makes really, she gets paid very well for it. So it's a pretty good gig if you want to do it. Only one person? Maybe, kind of, yeah. And again, even if you don't go into derm specifically, you will get a crud ton of it if you do family medicine or primary care, of course. I mean, gosh, you will. So going into this, am I just rambling on there for a couple minutes? History is important. Your history is important. It's one of the few times where, again, once you get good at this, you'll be able to walk around and be like, bam, 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 I got this. This is one of those things that you're going to have to ask a lot of questions and spend the time if you really want to get to the bottom of some odd rash or some odd dermatological finding. So approach to the patient. And again, no, and this is pretty much indicative of anything that we do in medicine. medicine, but for derm, it can be as simple as you walk in the room and you go, yep, that's a ringworm classic. I don't even have to really listen to you anymore. Here's some stuff. See you later. But then it can also be incredibly complex. And that's where you have to put together all those pieces of being a competent PA. But hopefully you can get out of a little bit of this concentration in order to get information from your patient to help guide you in your history-taking skills. And then the last bullet point is just kind of going along with, just remember, every patient's different and how you approach them is going to need to be tailored to what you're dealing with. Much like the lecture that I gave you on, you have your focus versus comprehensive versus follow-up. That's what that bullet point's saying. And it's different in regard to a rash versus a growth. You know, yeah, that's a different history. So, history of present illness, I think we've got this one nailed down at this point. This is pretty much your big 8 for the most part. Again, I try to be standardized against each one of them across all my lectures to try to show you that you can, for the most part, use your big 8 to gather up pretty much anything you need. Any complaint you walk into the room if you're just like completely at a loss. Don't forget that in your holster. Just use your big 8 if you're losing your mind in there. It will, you can get a lot enough to develop an HPI. There are obviously some little bit of different things in here. You know, previous episodes, characteristics. Characteristics are really important for derm. And again, that's just, well, tell me about that. Is it red? Is it itchy? Does it ooze stuff? Is it only itch at night? That's what characteristics mean. Give me some details. Give me some description of what's going on, what you're experiencing. So I've actually given you my rash HPI. This is what I ask for the most part. So print it out. If you want to, laminate it, use it, whatever. This is pretty much my questions that I use whenever I have a person that comes in with a rash. And again, not a ringworm, but like, I don't know what this is. I had a lady last week in Kramer, she was covered in head to toe in a rash, and she said she had sun poisoning. And I was like, it was unbelievable. These are the questions I straight up asked her. And pretty much 95% of my rash patients, I'll ask them this stuff. The last bullet point, you know, is your associated symptoms. Again, that can be way longer than that, because essentially your associated symptoms are you going through your review of systems and just busting through some of them. You may, I'm sure you get your viral exanthem. I don't believe you probably get that in this section. You'll probably get your viral exanthem lecture in your peds section. I'm assuming. I don't know. I haven't looked at your schedule. But in that case, like kids come in with rashes all the time. 9 times out of 10 it's just a contact dermatitis, meaning kiddo went and rubbed on some oil or something and it broke him out. But a lot of times it's secondary to viral illnesses. So you have to ask. So if you see that up here, you're like, why are you asking about upper respiratory type symptoms? It's extremely common. Kid will come in, or a teenager come in with a rash. I'll be like, have you been sick in the last 2 weeks? Runny nose, fever, coughing, sore throat, da-da-da-da. Yeah, okay, that bumps up viral exanthem. So that's what your associated symptoms means for derm. You can pull from any one of your other review systems that you know. Why would I ask about sore throat in a rash? Yeah, happens all the time. I've told you stories about where I've actually diagnosed people with strep just from their rash. They come in with scarlet fever. It's classic. Mom's like, I got this rash, I'm sick of it. I'm like, let's strep them, swab them. Sure enough, they have strep throat. So don't ever overlook that. It's a very classic scarletine rash. In the notes section, I've actually written some stuff out for you that I always ask. It's really important. Anybody here that's ever went to the doctor with a rash has probably had, hopefully, these questions asked of them. Changes in soaps, changes in detergents, changes in perfumes. Anyway, you can read those on your own, but this is an excellent an HPI development for someone coming in with a weird skin disorder rash. You can use it. And again, it doesn't always have to be rash. If they came in with a growth, like, or a mole. Let's say it was a mole. I have a mole, I'm really worried about it. You can still somewhat utilize that. When did it start changing on you? What about it concerns you? It was brown, now it's black. Is it bleeding? Is it itchy? Is it spreading? You can still utilize this somewhat. Any questions over that? I know you understand HPI. I just want you to take the HPI cookie cutter and be able to go into each one of your courses and understand how that's going to help you develop for that course. So I always do review systems first, but I decided to start putting it after the HPI bit. This is your review of systems for Integument specifically. This is absolutely no different than the sheet that you've been provided throughout this year, so no curveballs here on this either. It's exactly the same. Color, underneath it, you can see, obviously, I know you understand what color means. Color of their skin, color of the lesion, color of the rash. Apply that to whatever you want, whatever they're coming in and complaining of. Pigmentation, so again, this would be in regard to a mole, a freckle, or some type of macula that they were concerned about. Scaling or dryness, people can come in with just complaints of dry skin. They'll come in and see you just for dry skin. Is it excessive? How long have you had this? Do you have any scaling with your dryness? What makes it better? What makes it worse? Rashes, we kind of already covered that in a couple slides before with the example that I gave you. Just to give you want to know location, description. Is it spreading? Is it itchy? Are there exudates? Exudates is a fancy term basically for crusting or oozing or just some type of fluid coming out of it. Lesions, hives. Hives are scary. Has anybody ever seen anybody here with hives or urticaria? It's pretty intense. Bleeding, so easy bruising or bleeding. People will often come in with, I just have really bad bruising, I don't know what's up with that. I've had patients come in with that before, and they're like, we gotta figure it out. So bleeding and bruising. Nail growth, so if someone comes in with nail issues, again, on your review system sheet, it just says nail growth, but these are some of the things that could potentially help you dig out a little bit more what you're trying to get at. What are you coming in here for? What is your complaint? What can I ask you to potentially get this conversation going? Because that's what it's all about. You get a lot of nail stuff in family medicine, from fungal to paronychia to herpetic whitlow. Oh my gosh, you get it all the time. I love toenail removals. That's like mine. I love them. I tried to take off Nikki's. She has an ingrown toenail. I tried to do it in front. I asked her if I could do it in front of you guys, and she, of course, went down. She kind of went. She's like, "No, I'm scared." Has anybody ever seen a toenail removal or had it done on themselves? She's pretty brutal. I'd rate it right up there with like C-sections. It is like, oh my God, though I love them. I don't know why I enjoy doing them. It's quite fun. If you ever need one removed, come over, I'll take yours off. Nail texture. This is one of your review systems. So nail texture, texture is one of those things that obviously, what does texture mean? What does that mean? I can visually look at texture. But then you can also, this is where your palpation or touch comes in. I can feel and tell you the texture. This is smooth. This is rough. This is hot. You can also feel nails. You can feel that. You can feel hair and tell the texture of it. I know it sounds weird, but you've probably ever felt your own hair and been like, my hair's really dry. It's really brittle. Hair growth, that is one I do not like. I've had only a few, when I was at my family medicine practice, women that would come in with hair loss complaints, and I don't enjoy that workup. Because 9 times out of 10, everything you run on is normal. And you're just like, I don't know why you're losing your hair. Hair growth, hair texture, and hair distribution. But the beauty of it is loss of hair is a concern, but you can actually have excess hair, too much hair in a woman, which is usually what? Did I tell you? What, say that out loud? Hirsutism, yeah. It goes along with several different conditions, but PCOS is the main one that we know. But we tend to think of hair losing, but you can have patients that come in with a woman that's like, I have hair in places I don't want to have hair. So review of systems. Past medical history, again, you've been given this several times. I don't want to bore you with it. Past medical history, though, will be important if this is a case that is somewhat complex, meaning by the end of your HPI, you're like, I already know what this is. You're going to have to delve some more, and that's why you have to start going into the other sections of your medical document. You always want to know their general health, but there are many chronic conditions or illnesses or systemic illnesses that we know can lead to certain dermatological findings. And I've listed out some of the biggies, most common ones, but there are a gazillion different ones in this. Diabetes is the biggest, for me anyway, that I see come in with all kinds of skin changes that you have to be aware of. Then also a lot of your vascular insufficiency patients, if you remember from cards, they get really funky skin changes also. So if you're looking at it and you're thinking, God, this person has a cellulitis because both their lower legs from here down are red and flaky and swollen and hot, you have an infection, you have infection. Oh, but in your past medical you have vascular insufficiency and you're diabetic. No, you don't have cellulitis, you just have really bad vascular insufficiency. I'm not going to give you that freaking high-dose antibiotic I'm about to give you. Get it? You need to look at their past medical history. It's really good in regard to someone coming in with like a lesion complaint or a mole complaint. I always ask them, have you ever had a mole that you were weirded out or concerned about that you had taken off before? And they will be like, oh yeah, 2 years ago I had a dysplastic da-da-da-da, and you're like, okay, that's pretty important. So if anybody ever comes in with a mole complaint, you ask them about their past removals. They will usually start telling you about it. Obviously, hospital, blood transfusion, immunizations. Immunization is something interesting, if you want to call it immunization, vaccination, whatever you want to call it. I like that one for shingles people. People come in with shingles, and I think they have shingles if they're an older person, even though, you know, you can get shingles before you're older, 65 and up, you know, they have vaccinations for that now. But I'll always ask about people's status in regard to that, especially if they're coming in to see me for shingles and they've never had that vaccination. I will tell them, you can get this. Psychiatric history is pretty important in derm. I know you're like, how's that handy? It is. I have seen people before who come in with just odd picking pothole marks in their, you may have ever seen it, people that pick at their skin. There's actually a medical term for it. You'll get it probably in one of your lectures. People come in, it's usually people who do drugs like meth addicts are very, very, very common for it. You'll see this in your family medicine practice. They'll come in for a rash, you think it's bites, you'll throw steroids at them, you'll think it's poison ivy, you'll think it's them picking at their skin. And they do drugs, meth, and they'll just sit there and pick, and they'll just cause all, it looks like a rash, but it's actually them picking at their skin. There are also certain psychiatric disorders where people will damage their skin. So again, make sure you go down that road if you've thrown everything else at them and you're like, I am not coming up with anything here. I'm not trying to bore you right now, but I swear this is important. This really is important. These are things that people will not delve in until you ask. You'll be sitting in that room going, does it itch? I don't know. You need to go further. Nutritional status is another really important one, especially for hair. Especially for hair, actually, it's the main one. Nails, somewhat, bless you, but definitely for hair, bless you again. Women, when they come in losing their hair or have issues with it falling out, other than thyroid, I'll always ask about their nutrition. Are you eating enough protein? It's huge, huge for nails and skin. It's important for all of derm, but hair's a big one. So ask about their nutritional status. What labs could you get to even check someone's quote-unquote nutritional status? What 2 labs? With the same word in it. Very good, but what in a CMP? You're right, I'm sorry, I kind of did say that the right way. In a CMP, very good. Say it loud. Albumin. There's something called, it has the word albumin in it. It's even a better indicator of nutritional status.
Bilirubin?
Pre-albumin. If no one's ever told you that, it's a better indication of nutritional status. And you have to order it separately. It is not included in the CMP. I had a geriatrician teach me that. And the reason why it's a better indicator is because it's half-life. It doesn't hang around as long. So it's like, if it's not there, it's really not there. You can order pre-albumin. Very good. Family history, obviously family history is important because there are genetic components to certain dermatological conditions that we know and see and deal in. You can read all those there. Eczema is a big one for me. If I have a mom that brings in kiddo, and which you can always tell eczema is kind of classic, but if you're still trying to figure it out, I'll say, is anybody else, mom, you or dad? Or she's like, oh yeah, me and my husband both, horrible allergies, eczema, asthma, the whole 9 yards. I'll be like, makes me feel better. Yeah, I think your kid's probably got eczema. There's a huge, huge familial component to eczema, and psoriasis for that matter. So ask. It'll help you feel better about your diagnosis, because that's essentially what you're trying to do. I wrote it out for you in the notes section. I know you've probably heard this triad before. If you have not, you need to tuck it away. It's huge in medicine, but it's also huge on your boards, because as you know, we love triads in medicine. It's eczema, asthma, and allergies. Have you ever heard of that or not heard of that? Okay, good. It's totally real. It's not one of that crap you memorize just to go regurgitate for a test. Those 3 things go together like peanut butter and jelly. Just go together. And why do you think those 3 things go together? What weird component out of those 3, if you have to think about pathophysiology? It's it's a hypersensitivity. Yeah, you have your IgE response that carries over. That's why they are interlinked. Or that if you have one.
Maybe they changed their mind.
Okay, I was like, are they like that? That door doesn't lock, does it? Okay, I just didn't want to be out there. They're probably like, I'm out. I don't want to go back. Hives is another odd one. There will be familial, there's a condition for hives. Anybody know about it where mom or dad could have it, kiddos have it? It's basically familial urticaria. Have you ever seen that? It's crazy. So if a kiddo ever comes in with, and again, I've told you this before, you probably won't believe me until you go out and experience on your own. People will not tell you stuff. You think they would just come in there and spill their guts. But you'll have a kid with hives and you're thinking, oh my God, should I give him an EpiPen? I need to send him to the ER. And then you go down your history and you ask mom, she's like, oh no, I had the exact same thing when I was a kid. We're like, hey, that's important. Yes, thank you. The last bullet point, I love this question. I always ask this if I think it's an infectious process like a scabies or this really isn't family history, but it's kind of goes along with family. Anybody else in your house experiencing the same thing? It will tell you a ton. Scabies is the big one. You'll have someone come in, I know everybody's like, ugh. You'll get you some scabies all day, every day in family medicine, and lice. You'll have someone come in with a rash. Scabies it's for the most part textbook. When you get that lecture, you'll know what I'm talking about, like where it's located. But then, it'll be in some places that you're like, it's not really scabies, what am I dealing with here, da 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 da. And And I'll ask, anybody else in the house experiencing this? And the mom will be like, yep, me, the other kids, and my husband, we all have it. It's all in the same place, and then they'll proceed to lift up their shirt and show you exactly. And you'll be like, y'all all have scabies. Yep. So, is anybody else in the house dealing with this as well? Because that's not that, it's just that person. That is an infectious process. It's also important, why else would that be important? To know who else up in that petri dish is sharing. Why else would it be important? Think about it. If you thought about a plan of care and trying to really take care of your patient. That's exactly right. You gotta deal with it all. So you have to identify, because you're gonna treat them, they're gonna go home, they're gonna come back 3 weeks later and say, I have it again. Well, that's because your bed sheets and your clothes and your mom and everybody else has it still. We gotta get rid of all of it. Additional components, you can kind of read through these. And again, this is no different than the medical documentation that I've introduced you to before. It's just helping you understand why some of the, because, you know, when you have, I love when we ask the question about, do you work? You know, do you work? Where do you work? You're probably in the back of your mind like, I'm not asking this. Other than if it was like a musculoskeletal, like if they were a bricklayer or did something that would hurt something. These are some of the reasons why we ask them those questions. So if you ever had someone that came in with like a complaint of rash on their hands, Sheldon, we had our patient that had the numbness and tingling. We asked her, we were like, do you do anything with your hands where you dip them in like chemicals or they've been exposed or anything like that in your work, in your occupation? That's why you ask about occupation. What do you do that could potentially have caused this outbreak here on your body? Travel's really important. I always ask that one in my rash, as you saw in the previous slides. In my rash questions, especially if there's any other weird symptoms going along with it. Like, have you traveled outside this country before in the last 6 months? It's important because there are certain issues that infectious processes or exposures in other countries that can come back to you in a rash type form, and you need to be aware of that, especially if they have like fever, diarrhea, things along those lines, and a rash. You need to ask, have you been outside this country? I had a lady once, this was at my family medicine practice, she came in and she was covered in a weird rash. They all look the same after a while. I was quizzing her down and I was really at a loss. And she was fine overall, other than she had some joint soreness, which kind of put me into the panic zone just a tad bit, because rash, joint soreness, I was like, okay, that's not just a contact dermatitis. So I started quizzing her down, and it turns out, because I went down my little check sheet of all this stuff, 2 weeks before she had went, and I can't remember what country it was, and she was swimming in the ocean, and I guess it was the migratory time for like little mini jellyfishes, and they had like touched her. They were all in the water, and they had touched her just enough to where it caused a full body dermatitis on her. I mean, like, it was unbelievable. But when she said that, I was like, oh, okay, like you submerge yourself in with these freaking creatures, and she's like, yeah, I mean, everybody does it, it's like what you do. And that was what was wrong with her. So it made me feel better. I was like, okay, I really think you just had a reaction to those things touching your skin. But I never would have known that. Drugs are important, especially for your kids. If they come in, kiddos have that rash, that drug eruption rash. You always want to ask mom or dad, has kiddo taken any kind of antibiotic in the last week, 2 weeks, 3 weeks, 4 weeks? It could actually be delayed up to a month. I've seen it delayed up to a month. Because again, you know, drug is a delayed hypersensitivity reaction. And mom will say, yeah, 3 weeks ago she had an ear infection, went to the doctor, he gave her amoxicillin. I'm like, your kid's having an amoxicillin rash. That's what's going on here. Another classic one is your mono patient. that has mono, went to their family or urgent care. They just said, you got strep, here's some amoxicillin. They have mono. Mono and taking amoxicillin causes a very bizarro mono rash. It causes a rash on them. So just know that. And you'll say, okay, you need to stop that amoxicillin. Let me do a mono spot on you. Yep, you're positive for mono, not strep. That's why you have this bizarre rash all over your body. Has anybody ever seen a mono rash secondary to amoxicillin? So drugs are important. Social, this is important, so please don't overlook this, especially in your pediatric patients, and you would think that this is not an aspect you need to look into, but you do, it's sad. Poor living conditions, children that are being abused, children that are not bathed properly, their clothes are dirty, they don't have running water. You'll have kiddos that come in with horrible impetigo, and you'll treat them, and it never gets better. And you just need to be mindful of their living arrangements if they're not being taken care of or neglected. And not even neglect, but just, obviously, mom and dad are not aware, like you need to bathe kiddo, you need to wash their clothes, you need to be mindful of that. Do not overlook that in your kiddos. It's a hard conversation to have, but you need to understand that. Not everybody lives in an awesome, clean, good home like we all did or do. Smoking, yes, we all know smoking and drugs and alcohol do lots of bad stuff. Personal habits are also important. If you have someone that comes in with a hair or nail complaint, especially hair, this is a common finding in African American population. Little ones will come in with issues going on with their scalp. It's broken out, she's losing patches of her hair. It's because, be mindful of the chemicals that they place on their scalp, but then also the tight braiding that they do, that African American moms will do with the kiddos' hair. It can actually cause a lot of issues, and they will lose their hair. And they just don't put those two and two together. So always ask, like, tell me about your hair. What do you put on your hair? What do you style it with? Do you have tight braids? How do you have, those are questions you need to ask. I don't know, is anybody just like thinking, oh my gosh, I never thought about that? Or is this just kind of general stuff that you would have already known? I always wonder. Because when I was a student, I didn't. I get in the room and I was like, what? I mean, I don't know, I never really thought about these types of things. Because again, you get in there, right, especially after your first 3 months out, and you'll be like a deer in headlights. You'll be like, I have no idea where to go with this. I don't know, that's what I hope you take away from this, is it'll feed you a little bit of how to ask. What to ask. That's half the battle, right? Any questions over the history? And again, tailor it to whatever type of visit you're having, whatever the complaint is. But those are the biggie things that you need to incorporate every time if you're just sitting there going, I really need to make sure I get a lot of information because I don't know what's going on with you. Any questions over that? It's okay, no, nothing is too dumb or stupid, or don't be embarrassed, please. Okay, physical exam. The physical exam is, again, extremely straightforward. So I'm going to talk about some stuff before we get it. I mean, because basically this is it. Yeah, your hair, that's it. That's all there is to this. There's no technique to this. But I'm going to give you some tidbits that have helped me along the way when I do my derm stuff. And again, this is nothing groundbreaking. Approach to the physical exam. So this is something that you often will encounter when you go into your room to do your physical exam. 9 times out of 10, especially if you go into urgent care, ER, family medicine, whatever, you're going to be doing a localized, they come in with a complaint. You're going straight for that area. You don't have to do the whole shebang. But there will be instances, and I actually have a third lecture, and I'll give that one to you as well. I forgot to mention that earlier, that I actually gave the students last year. It is a mini lecture on what is composed of a complete dermatological comprehensive skin exam. I give you the indications of when you need to do it, because it's very clearly defined by the Dermatological Society in regard to when you need to do a full derm exam versus localized, and I'll give you that one as well. I will not test you over it, it's just a tool for you to utilize. But again, much like whenever, you're a student, you're like, I don't know how to do a focus versus comprehensive, I'm confused, what type of visit, that kind of goes along with your skin exam as well. If you're in derm, you're gonna be doing a lot of, oh my God, I just noticed your shirt. That's amazing. Does it show everybody? I actually was looking at t-shirts yesterday to buy. Show everybody. A girl has no name. Does anybody know what that means? Please tell me you do, because if you do, you're gonna get like 10 points. I'll put you on my good list. It's Game of Thrones. Did you watch the episode the other night? Of course you did. Good job. I love Jon Snow. I'm secretly. I'm pretty sure that's what my kids are gonna be for Halloween. The baby's gonna be Jon Snow and Jordan's gonna be Daenerys. So, anyway, yes. I'll get started on that immediately. Again, just know, you can do a focused, you can do a head to toe. The head to toe one takes a long time. So that is gonna be, has anybody ever, every year, because I've done massive sun damage, I go to my dermatologist and have full on, just so I can make sure there's, because you can only see certain parts of your body, to make sure I do not have any moles or areas that are suspicious. Does anybody ever go once a year to their dermatologist to get the full? I do too. It's very smart to do if you've done sun damage to yourself. That is an example of a comprehensive derm exam. But it's funny how fast my doctor does it. It's like, okay, you're good. I'm like, really? Are you sure that's not cancer? One more time. Anyway. 95% of you will go out. I have a derm rotation that you will go out on in your clinical year. Unless a student's just like, I hate this, I do not want to go on derm. I say to everybody, because again, I feel like it's a really good foundation rotation for you to go on. And the gentleman that you go with in Ardmore is amazing. So every one of you will go out on a derm rotation. He will teach you all this good stuff. I'm going to briefly go over these next couple of slides. This is just ideal conditions that you need to have when you do your derm exam. A warm environment, obviously, good lighting. Fluorescent lighting can sometimes bleach out or have issues with people's eyes in regard to seeing things. If you can, natural sunlight, daylight is the best thing when doing an exam. Of course, have the lights on in the room, but if you can get somebody by a window, if you're really struggling to see it, it tends to pick up better. Now granted, a lot of times, my clinic as well, you don't have windows in your clinic rooms. But if you're really trying to struggle, go take them to a different part of the clinic and put them by a window to try to really get a good look at it. It absolutely helps with skin stuff. I know a lot of time with our sensitive exams, you think about undressing a patient. Don't ever feel embarrassed if you're really concerned about like melanoma or doing a really good skin exam. You can have your patient also undress for that. That's totally appropriate. Because again, there are places that melanoma can arise that would be covered by clothing. So don't forget that. You'll get sued if you miss it because it was on their buttock or vaginal introitus because you didn't undress them. Because again, if you ever went in a teeny bed, you're exposing all of those areas to sun that otherwise would be, because you think you wear a bathing suit, so it would be covered up, not in a teeny bed. So you can have them undress. My last bullet point there, again, if they ever do become, take their clothes off, just make sure you have a chaperone present and document that you have a chaperone present. It's a really important thing to document. So just some basic tips. Tools, there's tons of really cool tools that you can utilize in your derm skin exam. You don't need a lot of them for the most part. You do need, at all times, a ruler. I've told you guys this a million times. I try to beat it into you. A ruler. It's your best friend when you're doing any kind of derm, anything that you're needing to measure. You have to measure and document derm stuff. Your Maxwell's has a little built-in ruler on the back of it. If you do not have a Maxwell's, I still have some up in my drawer if anybody wants one. I gave one out to all last year, and some of you here, but if you need one, I have really nice new ones, come to me and I'll give it to you. You always need to have that in your coat pocket. You cannot depend on your room to have a ruler. Again, just go through these. I'm not going to sit here and go over it. You'll get more detail when you go into your lectures and use that. I will bring up one. It's in the middle. It says gauze pads, tissues with water, makeup. People don't think about that. They'll go to do a comprehensive exam on a woman or needing to look at skin. You have to make them take their makeup off. They're gonna get mad about it, but you're like, I can't see underneath that. You're gonna have to remove that so I can really get a good look. So don't forget to have women take off their makeup if you're ever needing to do anything in their face. You'll get in trouble. This is just, you've probably seen these. This just helps you magnify better to look at skin. If you're ever having issues with the naked eye, which a lot of us do, it's hard to see some, especially if it's a tiny mole and you want to see changes with it, you can absolutely use these. These are in most clinics. And it's really cool. You just stick it up to the lesion and you can see every stinking detail of it. It's amazing. A really cool thing I like to do, and it's in the slide above, there are goggles or a magnifier that you can stick on your, it's like a head lamp, and it just pulls down, and it's like, you've probably seen a Good Shepherd or if you've ever shadowed or anything. And it's a magnifier that actually frees up your hands. So you can actually look and manipulate with your hands. Derm is one where don't be embarrassed. If you cannot see it with your eyes, you go get a magnification to help you do it. Technique, read this. Some of the main points about this are, you just want to make sure that you're doing it in a standardized approach each time. If you are going to do a comprehensive examination, just every time do it the same way. You'll get better at it and you won't be falling off doing things out of order. The best way to usually do it is head to toe. People will tell you to do that. With most things, especially when you're doing like your comprehensive physical exam, that's usually the way you start. So scout and just work your way down. It's the easy way to do it. You can't miss it. The last bullet point, we talk about this a lot. I have students ask me, you know, well, what do you do whenever you're doing an exam and you don't want to say everything looks normal, everything looks good? What's the appropriate way to tell patients? Because, you know, patients, if they come in with a mole and you're sitting there eye blocked, they're going to be like, is it really bad? What do you think is cancer? Tell me, what do you think? What does this look like? You're going to be put on the hot spot. And it's always a hard, you're like, what do I say? And some people don't agree with this. I'm all about saying, look, I think it looks fine. Or somebody was saying they got in trouble for saying normal or something. There's no right or wrong. You'll get in that situation and you'll start flubbing and you'll be like, I don't know what to say right now. It's okay, just tell them. I think it looks good, it looks fine, it's normal. I don't see anything concerning, that's kind of my go-to. I don't see anything concerning there. If you are worried about it, like you look at it and you go, oh my God, this is melanoma like I've never seen. You do not have to tell a patient that if you want to get some further testing, because that's always the right thing to do, right? But I'm really honest. I don't just sugarcoat and be like, yeah, I think I wouldn't worry about this. Just say, it looks concerning to me. In order to give you the best care possible, we're going to biopsy this. We're going to work this up further. We need to do some more testing on this. That's a really nice way to say, I am worried about this. Talk to your patient and tell them. It will make them feel better. Is everybody cool with that? I know that's a hard thing as a student when you get in the room. You're just like, yeah, it looks great. I don't know. It looks horrible. You can convey that message. And I wrote in the comment section, my dermatologist, and I think probably because I'm a provider, I don't know, everything he looks at, he'll say it out loud. He's like, this is benign. This is fine. You're worried about nothing. This looks good. And he does. He says it out loud. It makes me feel better. Okay. Gosh, a lot of different things here. Some of the main things I want you to take away from this, Anytime you're doing a skin examination, don't ever forget to look between toes and fingers. And again, it's just things that you honestly, you probably wouldn't think about it unless someone said, when you're looking at skin, there's skin in between there, there's skin in between toes. Look at palms, soles, in between toes, and in between fingers. And in actuality, there's some very pathognomonic skin changes for certain disease states that have to do with palms, soles, and in between. Scabies is actually one of them. It's very common, scabies, to be in the web spaces of the fingers and the toes. And if you see it there, you're like, I really think you have scabies. It just migrates to that area. You'll get that lecture. Another one is the rash that accompanies syphilis. It will be on the palms and the soles. It is bizarre. So that's why if I ever have like a male or a female come in with like STI concerns, I always look on their eyes. Say, let me look at your hands, let me look at your feet. And you know we have a huge outbreak of syphilis right now in Oklahoma City. A lot of people are like, wow, I thought that went away, and I didn't know it's back. And it will kill you. I tell my patients that. You will die from this because it will turn into neurosyphilis. So that's what that's saying. Look in between things. Also, if you're ever concerned, you always have to look at mucous membranes. People miss that all the time in derm. They don't even think about that. But you have to look on the, you can get cancer there. Inner lip, nose. I think in ENT, Nikki may have told you a story about the lady that actually had, it was a type of cancer that was on her inner, of her conjunctiva. You can get it there. So if you don't look and you miss it, that's going to be on you. So look at mucous membrane areas. The third bullet point are just saying that's areas that touch. So armpits. If your patient is large and has a pannus, a large abdomen, and I'll show you a picture here in a minute. You have to pick up their, have you ever heard pannus? Is that the first time you've heard that word? Okay, you need to know this. Pannus is a large abdomen that laps over. So basically you could stick your hand up in between the abdomen and the back of, does that make sense? I'm trying not to like say it without. You will get this, tons of it, especially in your diabetic patients, especially in your women. They will come in with yeast. And you'll go to pick up their pannus, and it'll be just full of yeasty rashes. Large breasts also. If women have pendulous breasts, you have to pick it up. Because the skin-to-skin contact, it's wet, it's dark, it's hot, and it's a breeding ground for yeast. So that's what that third bullet point means, is make sure anytime there's skin-to-skin contact because of body habitus, you pick it up and look under it, because there will be something there. Yeah, that is a rough one. The pannus is pretty rough. You can find a lot up in there that's not supposed to be there. I'm just looking, I'm sorry. Let me look here. I don't want to confuse you yet, because you're going to get your lectures regarding primary and secondary lesions, but I want to introduce that to you right here, because that's something that people are like, what are you talking about? There is a difference between a primary and a secondary lesion. That's kind of that's a better. That's not a basic thing. Is what I'm saying. Like if you throw that out there on your rotation, your preceptor's gonna be like, God dang, how do you know that? A primary. There are certain conditions. Pityriasis rosea is one of them. You'll have something called a Herald patch. That is the primary lesion. So a person will get the primary lesion first, and then they break out in this different type of rash on their body, and those are the secondary lesions. So just put that into your head right now, and when you get to those lectures, you won't be like, what are they talking about, primary, secondary? Syphilis is another one that have primary and secondary lesions. You'll have the primary on the penis, and then the secondary will be the hands and the feet. After you've done your visualization, then you can go in, that's what the last two bullet points are. Then you can go in and start your palpation and touching of it. you're gonna note temperature, you're gonna note if it's wet or if it has moisture. You're gonna note the texture. Any questions? I know it's a lot, guys. Yes, sir, yes.
So, some of the conditions you said could be infectious, and a lot of the times we're told to use bare skin so we can feel it.
Yes.
So when should you be wearing gloves, when should you not?
This is, honestly, I'm gonna give you what a professor needs to say to a student, I'm gonna tell you what I do. Well, that's realistic, right? You should always wear gloves, and I think that might be in there somewhere. You always wanna wear gloves if it's an infectious process. How about that? You do. But I will tell you, there are times that I will, unless it's dealing with their genitalia, because I don't wanna make them feel weird or uncomfortable, I will not wear gloves. I just touch it. Because I can't personally get a good feel for something unless I touch it. But there'd be a lot of people that'd probably be like, you should not be doing that. So there's two answers. Always wear gloves if you think it's infectious or if it's in a sensitive area, you know, like the vagina or the anus or the penis or the scrotum. But there are gonna be instances when you're out practicing 2 to 3 years that you're gonna rip the gloves off and be like, yeah, okay, I tried that, now I've got to really touch this. Just make sure that if it is infectious on the patient, don't, even if you want to get a good feel for it, if you have any broken skin, don't still wear the gloves. You know what I mean? Like, you know, you don't want to get it into your, whatever it might be. But that's a great question, and people always struggle with that. I don't wear gloves. I should wear gloves probably way more than I do, but I'm just one of those people, I don't give a rip. I'm not worried about. That's an excellent question, and you're gonna come up on this. One of the docs I work with at Family Medicine, he stinking wore gloves when he just did his, like, listening to their heart and lungs, and it just annoyed me. But that's just who he is. That is the way he was taught, and he wore gloves, and that's okay. If anybody here does it, you're fine. But I just am like, why are you wearing those gloves all the time? But that's a great question, a good question. Which that's kind of written, not that, but going into the sensitive area. I wrote it in your notes section. There will be instances you need to make sure you look at their buttocks, their anus, their penis, their scrotum, and their vaginal area. Don't overlook that. I had kind of talked to you guys about that if you rotated with me on your pelvic exam day. There are many instances where there are skin changes in the area, you know, like when you have the woman up in stirrups before you do your vaginal exam. People just brush by the external exam. They don't even look. I know a woman that was in our family medicine practice. She had melanoma, and it was right outside her labia majora. And they didn't catch it because no one ever, and she died from it. But again, it's not an area that you really think of, right? That people get melanoma, but you can, absolutely. But then also for your herpes. I can't tell you how many times I've seen herpes simplex outbreaks that are in that area, and they go up just to get, like, they think they have an ST, like out here for a pelvic, and you look first before you go into the vaginal canal, and they just have all those little tiny ulcerations everywhere. And I'm like, oh God, you have herpes. Look at the skin. Okay, so now getting into kind of the more specifics of it. I've already said this, no matter what you find on the body, if they're coming in for a specific complaint of a mole, a lesion, or whatever, you got to measure it. Please don't forget to do it. We do it normally in millimeters and centimeters, because again, for the most part, it's teensy tiny, right, on the skin. And if you have the time, which I know when you're a provider, you'll understand the constraints of trying to do a complete document. Try to measure it in 2 ways. Do the long axis, 3 by whatever, 2 by 7. Try. If you get it long ways, that's okay. Just measure something. I cannot tell you how annoyed I get when I look at a provider's note. If I'm either following up on a patient, they had an abscess that was drained, and I go look back in their note, and they never even document how big it was the first time we saw them. I'm like, I don't know if it's getting better or worse, because you didn't document it. I just have it that the redness is this big. I don't know. Is it better? document. Someone will come and they will read your note. It helps you for follow-up.